just to bring us back to what we hoped would be a reasonable flow to the afternoon, which was following the 6 individual presentations with a synthetic look at what works from Alex, then talking about how do we know what works in terms of the data and measurement issues, which is this panel, followed by the last panel being at what cost and what makes a program cost effective and feasible. So that's kind of the logic that we're trying to use. So in this panel, what we want to do is to talk about the data and measurement issues, which obviously are huge. And I think Mike earlier said, I think I got this right, Mike, the current data do not allow us to know what is going on in health services. If that's true, we're all in a great deal of trouble and need to figure out exactly what is possible to do in the circumstances. So to address those questions, we have 2 speakers with us. One is Nick Klazinga, who's the coordinator of the Healthcare Quality Indicators Project with OECD in Paris. This is a project that has established common healthcare quality indicators across now about 35 countries. These are the more affluent countries, but many of the principles and methods that have been used to do that are relevant, so Nick's going to share his insights with us. Nick also is a professor in social medicine at the University of Amsterdam. So the second speaker is Bruce Agins. Bruce is the medical director of the New York State Department of Health AIDS Institute and the principal architect of New York's HIV quality of care program. He has taken that experience and extended it across the world in the last 10 to 15 years, partnering with ministries of health in countries throughout Africa, Asia, Caribbean, and Papua New Guinea to provide technical support and coaching to build quality capacity in those countries. So we're going to hear from each of them for about 15 minutes, and then there will be time for questions and discussion.
Good afternoon. Pleasure to be here. And I'm going to talk to you a little bit about, as Sheila mentioned, a little bit about what the systems look like now to measure data. And so to think a little bit about what we might be able to get with what we have now and to think about what we would need if we want to expand beyond that. So I think really that if we think about this, what we want to accomplish, and we think about what the Holy Grail would be, and I think it's using real-time data in clinics for improvement that are available throughout the public health system to measure effects of changes and their eventual impact on long-term outcomes. The essential questions of how can we link process improvement work that occurs in clinics or geographic regions with improvements in overall population health? And what does it mean to strengthen a health system with respect to measuring quality? And when does that strengthening lead to sustainable change? And so I'm going to try to address this by sharing some examples, an example with you, a case study from Haiti. And so to give you a little context, the care system is described in this diagram where you see the Ministry of Health at the top that's supported by donors, including PEPFAR and the Global Fund. And they fund the Ministry of Health unit directly, as well as a series of provider networks that exist in the country. And then those in turn influence and support providers at the point of service, or POS, that are responsible for service delivery and implementing quality improvement work. And at baseline in 2004 and 2005, there was an electronic platform that was designed for a data reporting system or a monitoring and evaluation system. And they developed 2 different platforms financed by PEPFAR. One they call MESI, which is a monitoring and evaluation surveillance interface, and then an electronic medical record system that was then deployed throughout the ART, or the antiretroviral therapy clinics in the country. And initially, there were some limitations of these systems. I mean, there are still limitations, but at least at this point in time, these were used principally for collecting and or submitting data to donors, a lot of variation in these systems in terms of quality and completeness. The EMR was developed to focus only on HIV care, and there was little use of data for decision making. This is what the systems look like. On top is the monitoring and evaluation system, and that contains aggregated data on HIV, TB, family planning, and epidemiology and surveillance data. And then the electronic health record, or e-Santé, is shown below, and this contains longitudinal data about all care received by patients in the health facilities. This is an example, again, of e-Santé, and this is, as I said, an electronic medical record. It's in more than 100 sites, including government facilities, private hospitals, faith-based organizations, NGOs, and other networks, with a total of more than 160,000 patient records. 49 of the clinics have local servers, which eliminates the reliance on slow internet connectivity and allows automatic replication of data to a central repository. And this is just a depiction of the architecture of the EMR. Originally, the server was kept in the United States, and it's been transferred now to Haiti with a backup server, and it's done on open platforms. People are always asked in the ministry, how long did it take you to do this? And so they produced this slide. And basically, it took a year to roll out this electronic medical record system, which is pretty astounding when you think about it. And that included the training of the sites and then to get it operational. And this was done in partnership with the CDC, ITech, and Tulane University. So as I said, it took about a year. The required personnel included a team with an electrical engineer, database specialist, programmer, analyst, and a network specialist. And there are 10 people that were engaged in the operation of the system. It could be customized for different sites, and the training of a healthcare worker team took 2 days. The piloting process took about 3 months, and the cost of this was $400,000 plus an additional 10% for ongoing maintenance or TA. And as of today, there are 117 sites, HIV sites, and 3 non-HIV sites. This is just a list. You don't really need to read the list, but of the different kinds of reports that can be produced, and they can be either, as I mentioned, retrospective or prospective reports that generate case lists, and it also includes reminders. When this aggregated report is produced, obviously it has a bunch of different indicators. The one that's circled is the one I'm going to focus on, which was enrollment of patients on antiretroviral therapy who were eligible. And so this is an example of how the EMR can be used at a clinic level to improve quality. And here was an individual facility score, low for enrollment. And then I think, and I don't need to go into detail, I think you're all well aware of what a quality improvement process looks like. They go through and use these data as their baseline, design tests of changes, and implement them in the clinic. They were actually able to present their data at the International Forum. And they were also able to separate out their different interventions and measure them in a robust fashion, and found that by reducing waiting time in the clinic and preparing the clinic for the patients when they did come from the field, that they were actually able to show that those were the most successful interventions and resulting in improvement. And you can see their trended data over time at the clinic and when they initiated their intervention. But I think that's only part of the story when we want to see what works. We want to look beyond the clinic level, and the question becomes then, what was the impact at the national level? So every year, they call their national program the National HEALTHQUAL Program. They have an advisory board that meets, and they look at their performance data, and they define their priorities, set goals for the next review period, identify weaknesses and gaps in the overall system, and then provide feedback to the sites about implementing quality improvement. And this is in parallel with the quality improvement training platform and coaching. So for example, when they looked at cotrimoxazole prophylaxis or PMTCT results, they could track trends over time, and then they made some interventions at the system level. I show these to point out when they present this, they very proudly show that they only had a minor dip during the major catastrophes that affected Haiti, and that only 2 clinics were without power during that time, and the servers were able to keep the data coming in. But I think you can see the different types of interventions at the national level, at the policy level, that can affect change and result in improvement. Some of this is diffusion of guidelines and dissemination. integrating components of a fragmented information system, and then again, making the electronic medical record platform receptive to the different types of data and forms from pharmacy. So in terms of antiretroviral therapy, they had a target for 10,000 patients. Their performance was actually only 40% across the clinics for eligible patients. And this was really quite low given the amount of resources that had been going into the country for HIV programs. And so they began to look at what the factors might be, and they gave each clinic a specified goal to achieve. So they identified at the national level some of the limitations, and these included very stringent requirements for enrollment, lack of any kind of standardized norms for initiation of treatment, challenges getting CD4 counts to measure eligibility, and issues related to logistics of drugs. And so then had solutions at the national level to address those challenges, which are on the right-hand side. And I think, as you can see, then they could generate their data from their EMR. And again, this was the beauty of it, is they didn't really have to undertake a separate data collection process to gather the data from the facilities to aggregate it. And on this slide, you can see they reached 71%, but I got an email today that as of September, that rate is now up to 83%. And the different colors here just represent the entry of data submission into the EMR for the results. So I'm going to turn now, again, in the interest, I'm going to have to go a little quickly, but the Monitoring and Evaluation System, or MESI, which, as I mentioned, includes epi and surveillance data, maternal health data, family planning, and TB data, was set up, and this cost $200,000 with, again, a similar TA and maintenance. So again, a relatively inexpensive platform. And it's set up with a similar architecture across the country in terms of it being located centrally with regional ports and then facility-level data submission. There is a mandatory case reporting framework that goes into this and routine aggregate data reports. So here's a table that just simply shows the type of reports that are generated and at which level they're available. So they're actually able to, again, look at outcomes at not just the facility level, but at the regional level, at a level of a network, if there's a different provider network like PIH is there, and MSH had a network as well, and then national level reports. Their goal in the long term then is to integrate how the facility level data and the quality improvement work will feed back into this national report. And they're in the process now of programming platforms from the EMR and quality improvement data into this system. And I think at this point, identifying what's needed to make them both work becomes a challenge for them. And I think earlier today, when we heard some of the earlier presentations, there was discussion about what do we need beyond the system itself. So of course we need the technology and the power and the servers, but they thought through what was needed in terms of having a workforce that was capable of using the data, using the system, making sure that all the different decentralized units in the Ministry of Health were on board and using the system, and then a lot of rigorous data training to support all the different steps in the data system and data collection and reporting process, which you see on the side, and then of course both financial and human resources. So currently there is real-time data that's available to clinics through the electronic medical record, and that precludes the need for separate data collection, as I had mentioned. The EMR is primed now to integrate viral load data as that gets rolled out across the country, so we'll also have a more immediate outcome data report available in real time as well. They have begun to expand the EMR into primary care clinics outside of the HIV dedicated clinics, but had already included measures for both primary care and chronic disease in the HIV clinic system, and are planning to integrate the eSante database into the monitoring and evaluation system. And this is already budgeted. So then in closing, just to look at what some of the policy issues are and the challenges. Well, first of all, having the information system itself and having one that's agreed upon and a single uniform system that everybody's going to use obviously is key. Having the system set up politically. So, you know, there are a number of different bureaucratic units within a government system. The database may be managed sometimes in one part of a Ministry of Health, but the programmatic people in another part of the Ministry of Health. And once we get to crossing into HIV and maternal child health and how they intersect, it could yet be another part of the health department. So it requires a certain type of organization within the government system to allow this to happen, a certain alignment that really must happen. Clearly, there needs to be leadership and accountability within the ministry, and the systems need to get set up and running so that when, as often will happen, there's a political election that changes the leadership behind what's happening, that the system will continue to operate. I think I've already mentioned human resource and what's needed. I think a question comes up, do you need a special group of people who are data clerks that do the data entry, or is this something that gets integrated into the routine work of providers? And then to note that in most cases, there's no system for tracking community level interventions. In places where they're expanding with some electronic pen system and other techniques. So quickly, as my time is nearing an end here, I think some of the other challenges at the macro level, this is a disease-specific initiative. You know, what is it going to take to scale it up and also spread wide beyond the HIV care system? You know, again, across functions and diseases, it does not have capacity at this point in time to track the improvement work itself, to correlate what those interventions were with the data, so that has to be a separate process. And we have questions of attributions that we've been talking about, and then the question is what happens in the absence of donor support for these activities, since the donor support's providing support for the technology, the personnel in the ministry, and for communication systems. And I think we want to see then integration of services, systems, platforms, and funding streams with political will, resources, knowledge, and financial commitment that will create a lasting structure and processes to support ongoing data systems that are explicitly linked and correlated with improvement that would lead to a scenario like this, where we have the local process improvements that lead back up to the facility improvement that we can show, regional improvements, and then national improvements to achieve improvements in population health. Thank you.